It's the voice of Indiana County. It's WCCS 101.1 FM, AM 1160, and WCCSradio.com. Dr. Dan Clark is with us, IRMC, joining us to talk about colorectal cancer. It is Colorectal Cancer Awareness Month. Before we get to any of that, it's opening day. Pirates, Marlins today. Prediction for the season?
I don't know. It's going to be a tough one, I think. I hope they do better than last year.
Well, then there you go. There you go. We'll give them that. Our conversation this morning brought to you by Marcus & Mack, voted Best Personal Injury Law Firm. The Best of Indiana County contest, Marcus & Mack, a law firm representing injured people. Colorectal cancer and genetics is something that maybe 5 or 10 years ago people weren't thinking about all that much.
Right.
But in these last couple of years, especially, that connection has really been ramped up, hasn't it?
It really has. We've known, of course, about the breast cancer connection for quite a while. And as you know, I do genetic counseling, and I've been doing it for almost 17 years now. And I always say that, 17 years ago, I was checking for 3 genes, and 2 of those were BRCA1 and BRCA2, the breast cancer genes. And the other one was this thing called a MUTH gene, which is colorectal cancer. Mm-hmm. And so, but now we check for a lot more. And we know that a lot of colorectal cancer is associated with a genetic component now.
Now, how do you come up with that knowledge? Is it just looking and analyzing statistics, or is there something more scientific?
Both, actually. Statistics, as you know, we've seen younger and younger people in this country with both colon and breast cancers. Mm-hmm. And, that's why the American Cancer Society decreased their recommendation of age for colonoscopy to 45, because we're seeing patients in their 30s and early 40s with colon cancer now. And so we've had a lot more scientific data out there and a lot more understanding of what causes cancers. There's these proteins that help repair DNA as our cells divide and grow, and they're called mismatch repair proteins, MMR proteins. And we've found that these are cause an expression on the cell surface, and these proteins are expressed on the cell surface. And, they're MLH and MSH and PMS genes that's cause these proteins to be expressed on the surface. Mm-hmm. And now we can check when you have a colon cancer, when they do the biopsy, even before surgery, they can see if these genes are expressed on the surface of the cell, and it's called the phenotype being expressed. And if there is an absence of one of those 4 receptors or proteins on the surface, then that increases the likelihood that this could have a genetic component, and one of those genes has a mutation in them, so those mismatch repair proteins are not working to fix the DNA mm-hmm. as it replicates.
So we can then look forward to the day when seeing that to be the situation, maybe there's a therapeutic developed where, okay, it's mismatched now, let's match them up better, and we can do that through injections or some sort of medication?
Hopefully. I don't know if we'll get to that in the near future, but a lot of the immune therapy is working that way. If you have a mismatch repair and that leads to cancer, a lot of the immune therapies, and I'm no expert on this, I've been taught this by my medical oncologist, Dr. Ramanini and Dr. Mukamala at IRMC, that now these immunotherapies go in and they break the other side. Mm-hmm. So now the cancer can't replicate. So now if you have this mismatch repair and you have this break in the DNA, then there's some targeted therapies in different types of cancers that they can go in and it breaks the other side of the DNA, so now the cancer can't replicate. Yeah. So it's pretty amazing stuff that they've been able to do.
Would I be wrong to say that this genetic knowledge that we have now that can be a predictor of colon cancer or colorectal cancer, therefore would be able to diagnose it sooner in younger folks, and that is what's leading the recommendation to get it earlier?
Right, and the whole idea behind the genetics is that if you are predisposed, you should have the genetic testing, and we start screening even much earlier than 45. Mm-hmm. And the recommendations are if you have a family history of colon cancer, you should get screened 10 years younger than the youngest person in the family with colon cancer. So if you have a family member who was 40 with colon cancer, you should get a colonoscopy at age 30, not wait till 45.
Yeah. somebody that's, say, 20 to 25 or 26 years old, they're not going to think much about things like that. But as they get toward their 30s, probably it's a good idea for folks to really sit down with their family members and find out what is the medical history of the family. Right. What are some of those things that could be used to help us diagnose a problem in the future?
Right. I get asked the question all the time, when should I discuss this with my children? And the recommendation is when they're old enough to understand. You know, you probably don't want to be hitting this in their high school years or anything like that, because they don't need to worry about it in general in that time frame. When they get to their early to mid-20s and they're mature enough, it's probably time to sit down and say, hey, you know, your uncle had this cancer, you know, I've had this cancer, you know, we need to have you start looking at, you know, whether or not you need to be tested earlier or anything like that. Mm-hmm. And with these genetic mutations for colorectal cancer, it's called Lynch syndrome, and you don't develop polyps. You know, most cancers of the colon develop from polyps. Uh-huh. This is called a hereditary non-polyposis colorectal cancer, HNPCC. We love to put, you know, pseudonyms on everything. Uh-huh. But with that, you get them de novo. They just arise. And it's not like a polyp that takes 5 years or so to develop into a cancer. You get cancer arising directly out of the lining of the colon, so it doesn't take as long to develop. So that's why we do a lot more aggressive screening.
We're with Dr. Dan Clark this morning here on Indiana in the Morning, talking about colorectal cancer and the genetic component of diagnosing colon cancer. You've been doing this for a while, genetic counseling. Tell me about one of those sessions, sitting down with somebody saying, okay, this is what we find. You've come to us with this history. So we do the genetics on it, and we find out that this is you know, a part of your medical profile. Tell me about one of those sessions. How do you do that?
Well, it's really a 3-part session or 4-part. First, my nurse, Dad, goes out and gets the family cancer history from them, and I have a 2-page, 4-generational cancer family history that I like to have the patients fill out. And that's initial screening to find out if, do you look like you actually have a need for the genetic testing? And if you do, and most people by the time they're referred to this or self-refer usually do, then we have them sit down and watch a video about genetic testing and the ramifications and things like that. And then they have a teleconsultation with one of the genetic counselors from Myriad Genetics, which is the company I use for this genetic testing. They were the originators of the BRCA1 and BRCA2, and they're kind of considered the leaders in genetic testing. And then after the genetic counselor goes through the family history in detail, then they determine, okay, you do meet the criteria or you don't, or it needs further clarification. And then I come into the room and I sit down and I go over all that. And I make the final decision, does it look like you meet the criteria or not? I review the genetic counselor's notes and I get them sent to me immediately. And then I talk about the ramifications of the testing, you know, and what this means. And I often tell the patients, you know, even if it's negative, I don't call you up and say, hey, it's negative, don't worry about it, because there may be other ramifications. You're there because you have a family history. So we also look at that and determine the lifetime risk of cancers. And if you are at increased risk of cancer, we may develop different screening recommendations for you. So even if the genetics comes back negative, I tell them that I still want you to come back. I'm going to sit down and go over the results with you. And if it's positive, there's a lot more ramifications. Unfortunately, with colon cancer, the ramifications, you know, we know with BRCA, there's 5 different cancers associated with the breast cancer gene. Yeah. You know, there's breast, pancreatic, ovarian, prostate, and melanoma. Well, with colon cancer genes, there's even more. You know, when you look at colon cancers, you have stomach, endometrial, skin cancer. I have to look because there's so many. Kidney and ureteral cancer, you know, urogenital system. There's a small increase of breast cancer. There's a small increase of prostate cancer. Mm-hmm. So we sit down and go over all that, and I tell them then, you know, the ramifications of the testing will also be that, you know, your brothers and sisters may need to be tested, and your kids will need to be tested if you're positive.
Yeah, it's a toolkit, isn't it?
Right.
It really is. It's something in the tool chest that you can pull out and really help somebody improve their odds.
Absolutely.
Should cancer become a part of their medical profile.
Right. Yeah. And the thing to stress is that some people are like, well, I don't want to know. Well, you do want to know because we can do something about it. You know, this is something that we can prevent cancers. You know, it's not like some genetic testing we can tell you, yes, you're at risk for this, but there's nothing we can do to prevent or anything like that. In colon and breast cancer genetics, we can do things that put you in a higher screening, catch it much earlier. And it doesn't mean you're absolutely going to get cancer. You know, the different Lynch genes, depending on which of the 4 you have, your risk is from 20% to 85% chance of getting colon cancer. So, but if we do early screenings with more aggressive colonoscopies, we get you in with a dermatologist for annual skin cancer screenings. We check urine analysis on a yearly basis to check. We check PSAs. You know, we do a much more aggressive screening that you're not guaranteed to get cancer, but if we check it and we catch it early, we can cure you. You know, you're not going to die from this. But if you put your head in the sand, these can be aggressive cancers, more aggressive than the normal colon cancers, and they can kill you if we don't catch them early.
Well, colorectal cancer is the second most common cancer death cause.
Correct.
In America.
Right.
So it's a really serious thing.
Yeah. You know, lung cancer being number 1, and in men and women, it's the second leading cause of cancer deaths. Yeah. And unfortunately, it's probably one of the most preventable areas too.
Yeah. So we need to cut it off. So here's the deal. Next Wednesday, there is a colorectal cancer awareness health fair. It's going to be happening at the IRMC cafeteria. And all kinds of folks like you will be there talking about colorectal cancer, what you've just told us about genetics. There will be a dietitian there that talk about how you can reduce your cancer risk through dietary adjustments. There will be the gastrointestinal team will be there. All of this will be there. Can actually work with the Da Vinci robot that is used, that you use. There's a demo model that'll be there. Folks can actually take it and test drive it.
Right. You can sit down at the surgical robot. You know, as you know, we're one of the leading robotic centers in Western PA. And you can sit down at the surgical Da Vinci robot and sit down and use it. You know, it's the exact same robot that I use in the operating room and Dr. Billen uses for colorectal cancer. You can sit down and give it a test drive and see how amazing this thing is.
And there's the giant inflatable colon you can walk through, too.
Yeah.
I think the only thing cooler than that is if we made it into a bounce house.
Yeah, and they have the different, on the lining of that colon, they have the different representation of polyps and cancer and colitis and things like that.
Yeah, so, all of those things. So all of this is happening. There will be giveaways and prizes and some snacks and more, and you can actually schedule your screening on that day.
Right. Yeah.
All of those things. So this is from 5 o'clock onward. The health fair itself begins at 5. There will be discussion at 6, and you need to go to irmc.org/2024 or dial 357-7188, and you can get yourself all signed up for that. As it's the Colorectal Cancer Awareness Health Fair. IRMC Cafeteria next Wednesday.
Right. And I'm even going to have a short little video. I promise it won't be too gross or anything on, you know, showing robotic colon surgery up on the screen. So you can actually come and see the surgery as well, you know, from a video.
Yeah. Yeah. The success stories are just amazing with colorectal cancer treatment,
right?
And with screenings as well, and how taking those polyps and getting rid of them is really going to increase your odds. So again, it's irmc.org/2024. You can also call 357-7188 to get yourself signed up. Dr. Clark, thanks so much for the visit today. We appreciate it.
You're welcome. Always happy to come.
We appreciate the fact that we've been able to talk about colorectal cancer and maybe get folks interested in getting screenings too all this month. It's 8:25 in the morning. It's Indiana in the Morning on WCCS 101.1 FM, AM 1160, and WCCSradio.com.